nights and all the times, and we did like a
Good afternoon, and welcome to the American Heart Association's Transthyretin Amyloid Cardiomyopathy, ATTR-CM webinar series. We are thrilled to have you with us today for our second session in the series, Breakthroughs in ATTR-CM, CRISPR-Cas9, and the Evolving Trial Landscape. It is a pleasure to welcome you today as we explore the evolving science and clinical potential surrounding this complex and often under-recognized condition. Before we begin, a few quick housekeeping items to note. Today's webinar is being recorded. All participants have been muted upon entry to reduce background noise. We encourage an open conversational discussion, so please engage and share your thoughts, but note that time has been dedicated at the end of today's webinar for Q&A. Please submit your questions via the chat at any time throughout the didactic sessions, and we will address as many questions as time allows during the dedicated Q&A portion at the end of today's webinar. If you prefer to ask your question aloud during the Q&A later on, please use the raise your hand feature or request to be unmuted so we can call on you directly. A recording of today's session will be available in the coming weeks as an enduring educational resource on www.heart.org. My name is Devin Marie Keating, and I serve as a Director of Operations and Clinical Studies here at the American Heart Association, overseeing our work in cardiac amyloidosis. I would like to take a moment to extend a sincere and special thank you to Intellia Therapeutics for supporting the AHA in our efforts to impact and improve transthyretin amyloid cardiomyopathy awareness and education. The educational webinar series was developed to advance awareness, early diagnosis, and equitable care for transthyretin amyloid cardiomyopathy through expert-led sessions that educate, engage, and equip multidisciplinary teams with the knowledge and resources needed to improve patient outcomes. Today's webinar will provide an in-depth look at recent therapeutic advances and emerging research in ATTR-CM, including new treatment approvals, investigational therapies, and groundbreaking CRISPR-Cas9 developments, while highlighting ongoing clinical trials and future directions for patient care and referral. It is now my pleasure to introduce today's expert speakers. Our first speaker, Dr. Michelle Kittleson, Professor of Medicine and Director of Education in Heart Failure and Transplantation at Cedars-Sinai Medical Center. Dr. Kittleson is a nationally recognized leader in advanced heart failure and cardiovascular education. Her work has shaped contemporary approaches to heart failure care and clinical decision-making. Today, Dr. Kittleson will begin our session with an overview of recent therapeutic approvals and TTR silencing advances that are transforming the treatment landscape for ATTR-CM. Our next speaker, Dr. Mariana Fontana, is a professor at the National Amyloidosis Center at the University College London. Dr. Fontana is an internationally recognized expert in cardiac amyloidosis, imaging, and biomarker research whose contributions have significantly advanced early diagnosis and disease monitoring. Dr. Fontana is also the second author of the New England Journal of Medicine publication on NextZ, the first in-human CRISPR-Cas9 gene editing therapy for ATTR-CM. Dr. Fontana will guide us through the landmark trial findings and discuss what they mean for the future of precision treatment in amyloidosis. Have you both with us?
Thank you.
Please note the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA or ASA. The AHA and ASA does not endorse any product or device. Disclosures for Dr. Kittleson and Dr. Fontana have been listed here as well. With that, I would like to turn the mic over to Dr. Michelle Kittleson, who will help kick things off today with the approach to cardiac amyloidosis. Welcome and thank you, Dr. Kittleson.
Thank you so much. I'm delighted to be here. We're going to take a whirlwind tour, so I'm going to dive in and be prepared. There are going to be two audience response questions, and it will be delighted to hear your take. So let's start with a case because everything's more interesting when we talk about a patient. A 72-year-old woman presents with a 2-week history of shortness of breath. She has hypertension, paroxysmal atrial fibrillation, and osteoarthritis. Her medications include rivaroxaban, chlorthalidone, amlodipine, and ibuprofen as needed. On exam, her BMI is elevated, her heart rate is 68, her blood pressure is also elevated at 142/88, her JVP is 10, high, lungs clear, S4 gallop, 2+ edema. Her echo shows mild increased LV wall thickness, normal EF, mild aortic stenosis, and mild pulmonary hypertension. If this patient walked into your clinic, what do you think would be the most likely diagnosis? Cardiac amyloidosis, heart failure with preserved ejection fraction, hypertrophic cardiomyopathy, aortic stenosis, or pulmonary arterial hypertension. I will now hum the theme song to Jeopardy while you enter your response. Just kidding, I'm totally tone deaf, but you will have probably another 5 seconds to input your answer, and then I can't wait to see what you've chosen. All right, beautiful. Okay, this is fantastic. 64% of you said heart failure with preserved ejection fraction, 25% cardiac amyloidosis, and the rest split between HCM and pulmonary arterial hypertension. I am delighted that the majority of you chose HFpEF because you're thinking to yourself, this is a talk on amyloidosis, but this patient screams HFpEF. Older, woman, hypertension, obesity. This is the classic milieu. And that is where I'm leading you with this question. It is most consistent with HFpEF, but patients there's nuance to patient management. So let's do another patient. Let's tweak them a little bit. Still a 72-year-old woman, but now a 2-month history, a bit more indolent, fatigue and shortness of breath, no longer carries a diagnosis of hypertension, but has bilateral carpal tunnel, spinal stenosis, and peripheral neuropathy. Medications no longer include those antihypertensives. She's no longer obese on examination. Her blood pressure is not high. JVP is a little worse, and her echo looks exactly the same. Still, dyspnea, edema, preserved ejection fraction is the one-liner, but if this patient walked into your clinic, get ready to take the poll again. Now, what's your most likely diagnosis? Cardiac amyloidosis, heart failure with preserved ejection fraction, HCM, AS, PAH. You may begin. 10 seconds always feels like a lot longer when there's a dead air, so maybe I'll just ramble on until I see the poll results. All right, waiting. Oh, beautiful. Okay, so now 64% of you before said HFpEF, and now 85% of you say cardiac amyloidosis. And that is exactly why I do this exercise. Because if you just take the one-liner of the patient, dyspnea, edema, preserved EF, you may miss the nuances in the presentation that lead you towards the correct diagnosis. And I think one of my pet peeves in life, and I have many, is how we define a thick heart. The echo report might say left ventricular hypertrophy, but remember, increased LV wall thickness is not always too much muscle, i.e. hypertrophy. It may be infiltration into the muscle. So anytime you get an echo report and it says LVH, in your mind, translate that to increased LV wall thickness and ask yourself, is it muscle or is it infiltration into the muscle? This is important because, as you know, cardiac amyloidosis is a condition where there's a protein the body produces naturally that, for reasons we cannot understand, decides to infiltrate into the myocardium, resulting in a restrictive cardiomyopathy. There are hundreds of proteins that can cause it, but the two ones we care about the most are immunoglobulin light chains, AL cardiomyopathy along the spectrum from MGUS to multiple myeloma, a plasma cell dyscrasia, and the TTR transthyretin protein, ATTR-CM, which in turn can have one of two sources, a mutation in the gene, the variant form, ATTRV, or wild type. Now, a key here is the protein just doesn't go into the heart. It goes other places as well. There can be a neuropathy, a nephropathy unique to AL, gastrointestinal involvement, orthopedic issues, and that is the clue to the diagnosis. Remember that heart failure symptoms are but the tip of the iceberg, and you must be aware of what lies beneath. Think about other cardiac manifestations like AFib, AV block, pacemaker. Remember that about 15% of patients with severe AS undergoing TAVI or previously diagnosed with HFpEF admitted for decompensation have TTR amyloidosis when investigated. Think about that increased LV wall thickness and a voltage on the ECG that doesn't fit. The sensory autonomic neuropathies, the carpal tunnel, the spinal stenosis. So much of So when you meet that patient, dyspnea, edema, preserved ejection fraction, first ask yourself, is it the heart's fault? It's hard to unring the bell of misinformation. And if the patient's told they have heart failure, whereas their fluid retention is really from their kidney, their liver, or venous stasis, it's important to re-educate them to focus on the right organ. But if you're convinced it is the heart's fault, then make sure you are aware of the potential mimics for which there is disease-modifying therapy, including an infiltrative cardiomyopathy like amyloidosis. I am never one to advocate for more testing, but I'll always advocate for more thinking, and that is the key here. So much of medicine is pattern recognition, and once you know the pattern, the findings jump right out at you, where seemingly disparate findings lead to a satisfying, unifying diagnosis. So that's the first hurdle. Think of the diagnosis. Now let's go on to the second hurdle. Order the right tests and interpret them in the right way. So first, we take our clues from our history, ECG, imaging, and we ask ourselves, could this be AL? We check a monoclonal protein screen. If it is abnormal, you do not pass go. You do not collect 200. You remember that tissue is the issue and you biopsy something. But if the monoclonal protein screen is negative, you breathe a deep sigh of relief and order your radionuclide scintigraphy scan, which, if abnormal, leads to the non-invasive diagnosis of ATTR-CM. A few important pitfalls to the algorithm. I memorized in medical school, SPEP, UPEP, amyloidosis, not as sensitive as IFE. You must order IFE to exclude the possibility of AL. Second, I remember in medical school, we'd always say fat pad amyloidosis, not as sensitive as biopsying the organ of interest. You may start with fat pad or bone marrow because it is a less invasive surrogate site, but you can't end there if negative. And radionuclide scintigraphy is a triumph of our current management, allowing non-invasive diagnosis, but 10 to 20% of patients with AL will have a false positive scan. The median untreated survival of AL-CM is less than a year, so you would never want to miss that diagnosis by failing to order your monoclonal protein screen with which to interpret your radionuclide scintigraphy. Huge pitfalls to avoid so you lead to the right diagnosis. Finally, this is all put together in the AHA-ACC-HFSA 2022 heart failure guidelines. So now we'll go on to therapies, established therapies, which follow a very pleasing pathophysiological progression. The problem is the TTR protein. The solution is get rid of the TTR protein. That's one solution. So you can target production, because it's not that important a protein to begin with. You can target production in a very extreme way by doing a liver transplant, but thank goodness that has really fallen out of need in the current era of more effective ways to turn off production. We'll talk about the RNA silencers, the evidence for that in cardiomyopathy. And a foreshadow, Dr. Fontana will tell us about gene editing. The next thing you can do is take that TTR protein, which is the problem because it dissociates into fibrils that go into tissues, and stabilize it in its happy tetramer form so it won't cause trouble. Those are the stabilizers. We'll talk about tafamidis and acoramidis. And then a nod to the future, the holy grail of reversing disease, which would be the monoclonal antibodies. So it's very important to remember here that if you're targeting the protein by its production, silencer, or by keeping it in its form that won't go into tissues, stabilizer, you are not reversing disease. You are slowing or stopping progression. So it's distinct from reversal, which we'll talk about has some promise in the future. So the landmark trial The ATTR-ACT trial came out in 2018. Tafamidis versus placebo, reduction in mortality, reduction in hospitalization. Within a year, less than a year of the study coming out, the FDA, United States FDA, approved its use based on the strength of this data. Important things to tell your patients. Number one, you're not supposed to feel better after you start this medicine. It is there to prevent you from feeling worse, which is a plug for early diagnosis to freeze people at an earlier stage in their disease. And second, there is no established method to determine response to therapy or even what you are supposed to do if they are not responding. So you started, you are delighted that there are no side effects or important things to monitor, except high-dose statins should be avoided because of the risk of rhabdomyolysis. But short of that, it is a very easy, straightforward medicine to give your patients. We now have data from a second TTR stabilizer. Oh, hang on one second. I'm too impatient with my clicker. There we go. The second one is acoramidis, studied in the ATTRibute-CM trial. Acoramidis versus placebo, reduction in the primary endpoint, a win ratio of death, cardiovascular hospitalization, NT-proBNP, and 6-minute walk distance. A lot of clinicians like me, it's gosh, win ratio, what does that mean exactly? I'm so used to hazard ratios of death and hospitalization. So thankfully, the amazing clinical trialists also published a secondary pre-specified analysis where they focused exactly on all-cause mortality, heart failure, hospitalization, congruent results. So what do we know? ATTRibute-CM, acoramidis works. ATTR-ACT, tafamidis works. Two stabilizers that are effective in improving outcomes. And now let's talk about the silencers. There was some early promise with the FDA approval of patisiran and inotersen for use in progression of neuropathy. There were some post hoc and open label analyses that showed improvement for cardiomyopathy with surrogate endpoints. There were two early trials that one, Endeavor, was stopped early because of deaths in the treatment arm. The other had a potentially less exciting outcome endpoint of 6-minute walk distance. So if I was giving this talk a year or two ago, I'd say, gosh, I'm not sure what we can say about these. But now, thanks to the amazing work of Dr. Fontana and colleagues, I can tell you about HELIOS-B with vutrisiran versus placebo for 36 months met its primary endpoint of a reduction in death, cardiovascular hospitalization, heart failure, urgent visits, which led now to the FDA approval in March of this year. So this is very exciting. The landscape has exploded. We have two stabilizers, tafamidis, acoramidis, and one silencer, vutrisiran, that all work to preserve quality of life, prevent hospitalizations, increase survival, and CardioTransform with eplontersen, another silencer. We should have data next year. So really the question then becomes the million-dollar question, literally the million-dollar question, is which medication should you choose? And of course, the first way you'll try to answer this question is by going to the clinical trials, but the clinical trials can't really help us. It's really an amazing feat that if you look historically at when these trials enrolled and the type of patients they enrolled, that in consecutive trials, patients are healthier and healthier and healthier in their NYHA class, NT-proBNP, 6-minute walk distance, KCCQ, because of earlier diagnosis, better heart failure management, populations are less sick. You can see that with the survival curves that are progressively better even in the placebo arm of successive trials based on versus the treatment arm of the trial which preceded it. So that for HELIOS-B in the treatment arm, survival essentially approaches age-related survival, which is really kudos to the field, great for patients, but it means we can't compare these trials head to head. It is apples and oranges. So my take on the upcoming therapeutic landscape, if I have a patient with confirmed ATTR cardiac amyloidosis, the first question I'll ask is there end-stage disease? Remember, these don't reverse disease. They slow or halt progression. There is a point of futility. It's important to know when to say no. Then I ask myself, is there a non-medical characteristic like cost that may favor one option? When things are medically equivalent, cost is a good driver of choice. If there's neuropathy, vutrisiran makes sense because of the data. And if there are none of these compelling factors, then I ask the patient what their favorite may be. Guideline-directed medical therapy, we all know, is hugely important in heart failure, but you must think differently in cardiac amyloidosis because of restrictive physiology. The fixed stroke volume and dependence on heart rate means beta blockers are poorly tolerated. The fixed stroke volume means there's no flexibility to afterload reduction. Vasodilators are poorly tolerated. There can be reduction in congestion with SGLT2 inhibitors. So putting it all together, think about who's appropriate for disease-modifying therapy, think about heart failure management, and then, unless there is variant form with neuropathy, think about cost, access, and patient preference for choice of tafamidis, acoramidis, or vutrisiran, recognizing there's insufficient evidence to recommend one over another or combination therapy. Glimpses into the future. Well, I'm going to be very brief here because you're going to hear from the expert on this with Dr. Fontana, who will tell us all about the cool options of gene editing. And of course, then there's the holy grail of antibody depletion, which there's currently evidence of disease reversal with biomarkers and imaging with phase 3 trials ongoing. So when do you refer to an amyloid specialist? Think about it if you're not sure about the results of your diagnostic tests, because the prescription, at least in the United States, is hugely expensive and can be complicated. If you want your patient to have access to clinical trials, or you think they may be a candidate for advanced therapies. So in summary, we know that ATTR-CM is more common than you think, have a high index of suspicion in the face of clinical clues. Remember that non-invasive diagnosis is possible, but only if the monoclonal protein screen is negative, and we have 3 available therapies. We don't yet know what is standard of care, how to assess response to therapy, and how to manage asymptomatic patients. But it's a great time to be an amyloid specialist. And now I'm delighted to pass it over to my expert colleague, Dr. Fontana.
Thank you so much, Dr. Kittleson. Just as a quick reminder to all, Dr. Kittleson's slides and Dr. Fontana's slides will be posted in the coming weeks on heart.org as an enduring resource. And we have Q&A at the end of our session together with Dr. Kittleson and Dr. Fontana. But now we welcome Dr. Mariana Fontana, who will be providing us with a CRISPR-Cas9 deep dive. The floor is yours, Dr. Fontana.
Thank you very much for the invitations. I'm really pleased to be here with Dr. Kittleson this evening. But first, before going into what's new in ATTR amyloidosis, and specifically genome editing, I'd like to take back to the old, to this very seminal paper from a quarter of a century ago, established treatment paradigm which works across all types of amyloidosis. So what we learned from this study, and this was in patients with systemic AL amyloidosis, is that if we were able to reduce the new amyloid production with chemotherapy, then this was unequivocally associated with better outcome. A few years ago, Professor Gilmore, the head of the National Amyloidosis Center where I work, did similar studies in AA amyloidosis, the one associated with inflammation. And what Professor Gilmore showed is that if we were able to reduce the new amyloid production in AA amyloidosis, again, this was unequivocally associated with bad outcome. But imaging really took us a step further. So SAP scintigraphy is a nuclear medicine technique which can visualize the amyloid deposits with very high sensitivity and specificity. And what we learned is that if we were able to deeply reduce the new amyloid production, we could actually see in a proportion of the patient's net organ regression from the amyloid from the different organs. A similar observation was done a few years after by Philip Hawkins together with Professor Gilmore in AL amyloidosis. Again, in patients where we could achieve a deep reduction in the new amyloid production in patients with systemic AL amyloidosis, in a proportion of this patient, we could actually see net organ regression. You see here at the center of patients with large amyloid load in the liver, the spleen, and the kidneys. And just a couple of years after, you see all the amyloid is gone from the liver, and there was a massive reduction in the kidneys. And it amazes me that it took us 20 years to realize that the heart behaves in an exactly similar fashion. So, but SAP scintigraphy cannot visualize the cardiac amyloid, it just visualizes the amyloid in the heart, in the liver, in the spleen, in the kidneys, in the adrenals, in the bones, but cannot visualize or measure the cardiac amyloid load. By using CMR with T1 mapping and ECG measurement, we were able to show that the heart works exactly in a similar fashion. In 20% of the patients at 1 year, which responded well to chemotherapy, we could actually see net organ regression. But most importantly, regression of amyloid from the heart at 6 months was an independent predictor of prognosis. And why was that? Because until now, we were just able to measure the new production. But for the first time, we were not only able to measure the new production, but also the cardiac response to the reduction in the new production. And the proportion of the patients where there was associated regression, then these were the ones that were going to do better. So from imaging, we learned the unequivocal association between quantity of amyloid and organ function and outcome. We also learned that the natural clearance of amyloid in vivo is incredibly slow. So it exists, is there, but it's very slow. But also we learned that the amyloid clearance occurs different rate in different organs, and the heart is the last one to regress. But also we learned, and this one is the most important point, that the clearance is extremely variable across different individuals. So in the patient at the center, in the example at the center, we have a reduction in new production, but because the production is more than the clearance, then there is still amyloid accumulation. But on the example on the right, for the same reduction in amyloid production, because the clearance is higher than the production, that in these patients, we will see amyloid regression. So similar reduction in amyloid production will lead to a different outcome depending on the natural clearance ability. And it's because of this last point that took us another 10 years to learn that it was not just important to reduce the new amyloid production, but it was the magnitude of the reduction which was really the key. On the left, you see in AA amyloidosis, and you see the first column is SAA levels divided by octiles. When there is inflammation, SAA levels can become 100, 200, 300. And so let's say we reduce the SAA levels, which is the amyloid precursor protein, to 6, which is just outside the normal range. We think certainly this will translate in a better outcome for patients. But what you can actually see that an SAA level just outside the normal range is associated with a 4-fold risk of death compared to an SAA, which is within the normal range. Very similar pattern in AL amyloidosis. Initially, I've seen 25 years ago, we were happy to reduce the new amyloid production by 50%. Then we learned that 75 was better than 50, then 90 was better than 75, and now we want 100% reduction in every single patient with cardiac AL amyloidosis. And so how this treatment paradigm do apply to patients with ATTR amyloidosis? So you've seen from the previous presentation that in ATTR amyloidosis, we can reduce the new amyloid production by using different mechanisms. We can stabilize the TTR protein in the normal conformation with stabilizers, but now we are moving into reducing the production of the protein itself from the liver. And we can do that with gene silencers, but then we're really moving into the possibility of can we do that with genome editing and one single infusion. So you have seen the incredible evolution in the treatment strategies over the last 10 years in patients with ATTR cardiomyopathy. 10 years ago, there was absolutely nothing we could do with these patients, but now we have 2 stabilizers that have been shown to be very effective in delaying disease progression in patients with ATTR cardiomyopathy, and more recently also gene silencing, like with vutrisiran, again, able to reduce disease progression, and this was unequivocally associated with better outcome. However, some patients with ATTR cardiomyopathy do not respond to standard care treatment and continue to have elevated risk for disease progression and mortality. So what can we do more for these patients? So you've seen that over the 25 years of research in AA and AL amyloidosis, we learned an incredible amount in terms of not only the importance of reducing the amyloid production, but it's the depth of the reduction, which is really key. And this has been unequivocally shown in AL amyloidosis and in AA amyloidosis, just showing you the data. So achieving the lowest possible level of amyloid precursor protein is also likely to be important to maximally impact disease progression also in ATTR amyloidosis. And we can achieve that with genome medicine approaches. When we think about the therapeutic and investigational strategies to treat life-threatening disease, this has really gone through a very significant evolution. So we started from targeting proteins, then we move into targeting RNAs, and now we are very quickly moving in actually targeting DNA with genome editing approaches using single infusion. And the extensive history of genome medicine has really led to the first in vivo late-stage clinical trials of a CRISPR-based Cas9 therapy. And in 2021, were presented the results from the phase 1 clinical study for the first in human CRISPR-Cas9 gene therapy with Nexigur and Siglumer. So when we think about CRISPR-Cas9 technology, we have to look into the wider context because it has been explored for the treatment across a wide range of disease states. So not just transthyretin amyloidosis, which we'll discuss during this talk, but also sickle cell disease, transfusion-dependent beta thalassemia, hereditary angioedema, and then cardiovascular disease, type 1 diabetes, and cancers. So CRISPR-Cas9 therapy have really the potential to change how diseases are treated by addressing the underlying mechanisms. And why is that? Because with CRISPR-Cas9, we can make precise edits. And this is adaptable to a wide range of disease because theoretically, the CRISPR-Cas9 based technology can be applied to any gene in the genome. Provide a single dose treatment with the potential to have permanent effect on disease activity. And this is extremely important because I heard in so many talks and comments saying it's a once-a-year infusion. It's a single infusion for the rest of a patient's life. And of course, the reduced healthcare and treatment burden will have an impact on patients and society. So when we think about CRISPR-Cas9 gene editing, this can be achieved either in vivo or ex vivo. So in vivo is what we do in ATTR amyloidosis. So with a single infusion that takes only a few hours, then we permanently modify and inactivate the TTR gene. And this leads to a deep and durable reduction in the TTR levels. When we talk about ex vivo genome editing, what we need to do, we need to collect the cells from a donor or patient. Then the CRISPR-Cas9 is transferred into the donor patient cells, and then the modified cells are injected back into the patient. But what are the components of the CRISPR-based therapy? So there is a guide RNA, which recognizes specifically the gene of interest. And then there is the Cas9 RNA, which produces the enzyme, which is responsible for the precise editing. And the CRISPR-Cas9 complex is encapsulated either on a lipid nanoparticle, and that's what we do in ATTR amyloidosis, or in a viral vector. And when we think about ATTR amyloidosis, so the CRISPR-Cas9 genome editing complex is encapsulated in a lipid nanoparticle, which is delivered via a single infusion. And once it's delivered by a single infusion, that the LDL receptors on the hepatocyte rapidly takes up the lipid nanoparticle, and then the Cas9 enzyme is translated to produce the protein, which binds to the single guide RNA and specifically targets the TTR gene, leading to permanent inactivation of both the wild type and the variant form. And why it works? Because the CRISPR-Cas9 takes advantage of the cell's natural repair process to genetically address the underlying cause of disease. So focuses precise double-stranded breaks activity to a specific site within the gene of interest, following, again, one single infusion. But then let's, for a second, take a step back. And one of the things is like, why, of all the disease that we could choose, the first in human genome editing using CRISPR-Cas9 has been done on ATTR amyloidosis. There are a few reasons why that was the case. It's first because it's a monogenic disease. So we know that ATTR amyloidosis is caused by the misfolding of single protein. The second reason is because more than 90% of circulating TTR is synthesized by the liver. And we had a very good lipid nanoparticle that could safely deliver the CRISPR-Cas9 technology to the liver. Plus, we knew that knocking down TTR was likely to be beneficial because of 20-year research that have shown you in AA and AL amyloidosis. But also we know that knocking down TTR was likely to be safe because of the overlapping physiological condition with other protein, but also because of the extensive experience over the last 10 years with gene silencers. So ATTR amyloidosis was an ideal application to investigate the CRISPR-Cas9 gene editing therapy. And so, as I mentioned, one single infusion over 4 hours, then the lipid nanoparticle is taken up by the liver, by the LDL receptor on the hepatocytes. Cas9 is translated to produce the enzyme, binds the single guide, and specifically leads to permanent inactivation of the TTR production. But what's important is that how do we make sure that this is safe? So rigorous research has to be conducted to identify the guide RNA sequence with a high specificity for the gene of interest. And so the key attributes when we think about the single guide RNA is high precision. So we have to edit the genome at intended target sites, but also high accuracy. So we need to avoid validated unintended edits. And so we need to do a comprehensive guide RNA specificity assessment prior to the development of any CRISPR-based therapy. And when we think about the computational and empirical testing to help ensure the precision, this is a form of 3 kind of steps. First, identify potential logic for knockdown, then characterize the guide RNA candidates of target activity across the human genome, and then validate the guide RNA with high specificity activity to the target DNA. And the Nexiglutide and Ziglumeran demonstrated a lack of detectable off-target edits at therapeutically relevant doses. And this is an absolutely key component of any genome editing approach, making sure that there's no off-target genome editing at the therapeutic levels. And so the comprehensive computational and empirical testing helped to maximize precision on target editing of their investigation CRISPR-Cas9 based therapy. And so the steps are discover of potential off-target effects using independent library, then aggregate all identified genomic loci for validation or rejection of off-target potential, and that each potential off-target location is verified with deep sequencing. And these are the results following a single dose of Nexiglutide in preclinical models. What we observed is that there was 73% gene editing across the whole liver, and this was associated with more than 94% reduction in serum TTR protein, and this was sustained for 12 months. And no AEs after a single infusion were reported. So Nexiglutide appeared to be clean from the circulation after 5 days, again, after a single infusion, gene editing is done and then is out of the circulation. And knockdown was observed over a period of 12 months, so this was durable. But then what are the results in humans? So this one is the design of the phase 1 first-in-human genome editing with Nexiglutide and Ziglumeran. And the phase 1 has got a cardiomyopathy population and a polyneuropathy population. But let's start from the cardiomyopathy population. So these recruited 36 patients with hereditary amyloidosis or wild-type amyloidosis in NYHA class from 1 to 3. And the study comprised 2 parts. Part 1, dose single ascending dose. So patients were dosed, 3 patients of 1 milligram per kilo and 9 patients 0.7 milligram per kilo. And then in the dose expansion of the study, every patient, 24, was dosed at the fixed dose of 55 milligram per kilo, which is the equivalent dose of 0.7 milligram per kilo. The primary objectives were evaluate the safety, tolerability, and PD, so the TTR levels, and the secondary objectives were evaluating efficacy on clinical measure of cardiac disease, so validated measures of cardiac progression. And again, the intervention was just a single infusion administered over 4 hours. These were the baseline characteristics. And what's important to kind of observe here is that this population was representative of patients with ATTR amyloidosis, including patients with advanced disease. And this is shown by the high NT-proBNP level, very impaired peak oxygen consumption, very high extracellular volume by CMR, and there was a high proportion of patients with hereditary disease with aggressive mutations. 2 of the patients were homozygous for V142I, which is known to be associated with incredibly progressive disease. Importantly, no patients was interfamilies at baseline. Administration of single infusion was associated with a deep, rapid, and durable reduction in serum TTR levels in every patient following a single infusion. And this was independent of the baseline TTR levels and the genotype, with a mean absolute reduction of 18.9 microgram per liter achieved at 28 days, so extremely early on, with levels maintained virtually unchanged through the 24 months of observation. In terms of clinical changes, NextSeed was associated with stability on validated markers of disease progression, such as NT-proBNP, ultrasensitive troponin T, and 6-minute walking tests over 12 months. And when an individual responder analysis was done using validated criteria for disease progression, which you see here on the right, nearly 80% of patients demonstrated stability or improvement in markers of disease progression, with 83% of NYHA function class 1 and 2 and 40% of the patients in NYHA function 3 had no worsening in any of the 3 markers. Importantly, the evidence of stability or improvement was also demonstrated by stability or improvement in the quality of life and in the NYHA class. And although these observations were done in an open label study, the findings were coherent with the rest of the observations in all the validated markers of disease progression. Functional capacity was assessed with the cardiopulmonary exercise testing, and again, there was evidence of stability on the peak VO2 and VV-CO2 slope, which are strong prognostic markers, and deteriorate extremely rapidly in patients with ATTR cardiomyopathy. Imaging assessment of cardiac remodeling showed across a wide range of deformation and non-deformation-based parameters stability, with echo, but also CMR, including measurement of the Hamlet burden. Importantly, also when we look at patients with variant versus patients with wild-type gene, there was no difference in the degree, in the rapidity, the depth of the stability of the reduction in the new TTR production. And again, when we look at the validated markers of disease progression, there was no difference in hereditary versus wild-type disease. Importantly, the vast majority of AEs were infusion-related reactions and that spontaneously resolved, and there were no major findings. But what about the polyneuropathy population? This has been recently published in the New England Journal of Medicine less than a month ago by Julian Gilmore, and the structure of the study is the design of the study similar, again, part 1 and part 2 study, so single ascending dose and dose expansion. So 15 patients in the single ascending dose and 21 patients in dose expansion, where we see a 55 milligram and 80 milligrams, with the primary objectives being to evaluate the safety, tolerability, and PD. So again, the serum TTR levels. And second objectives evaluate efficacy on clinical measures of neuropathy. And what we found in these populations from a TTR level perspective, very similar finding to patients with ATTR cardiomyopathy, with a deep, durable, and sustained reduction in the TTR levels, again, as early as 28 days. And you see that the levels are virtually unchanged over the 24 months of observation of the study. But importantly, what we saw was not just stability in the NIS and modified NIS plus 7 score, which is one of the most comprehensive ways we can assess polyneuropathy in this population, but actually there was evidence of improvement in these patients, in both treatment-naive patients, but also in patients who had progression on gene silencers. And this one is the waterfall plot at month 24. The majority of patients experience improvement in the modified NIS plus 7 score, with the mean change at 24 months of minus 8.5. 72% of the patients had improvement in a modified NIS plus 7 score, which exceeded the clinically meaningful threshold of a more or equal than 4-point reduction. So extremely clinical significant findings. There was evidence of stability or improvement across also other disease-related clinical measures, such as NFL, which is an emerging biomarker to measure neuropathic involvement, Norfolk quality of life, modified BMI, and the P&D score. And as cardiologists, we are very used to use the P&D scope, which is a very crude measure of polyneuropathy, patients being able to walk, patients being able to walk assisted, and patient becomes wheelchair bound and bed bound. And there was a change even on the P&D score, which is an extremely crude but very clinically meaningful way to assess polyneuropathy and the consequences of polyneuropathy in these patients, which is extremely significant. And all the patients received the intended dose of Nexid, and all infusion-related reactions were grade 2 or less. 3 patients had an ALT or AST elevations more than 5 times the upper limit of normal, but there were no symptoms, changes in hepatic synthetic function, no prolonged thrombin time or clinical sequelae. Onset occurred between 24 and 35 days following infusion, and all returned to normal levels without intervention within 31 and 58 days. Importantly, 2 patients received 80 milligram dose and 1 patient received a 55 milligram dose, which is the dose which is brought into the selected for the phase 3 trial. The safety profile in patients with prior disease progression on patisiran was comparable to the overall study population. But what is the future? So I'm really excited to share that the phase 3 study, which is a randomized double-blind placebo-controlled study to evaluate Nexid in patients with ATTR cardiomyopathy, is ongoing, recruiting extremely well, with a target recruitment of 1,200 patients. Patients have been randomized 2-to-1 to a single infusion of Nexiguran Ciclumeran 55 milligram or placebo, and the primary composite endpoint is CV-related mortality and CV-related events. Key secondary endpoints are serum TTR, KCCQ overall score. Stratification is by NAC stage, TTR genotype, and concomitant tafamidis or acoramidis use versus no tafamidis acoramidis. The study duration dependent on the occurrence of pre-specified number of CV events, so is event-driven, and is a minimum of 18 months of follow-up. The majority of patients are expected to have more than 33 months of follow-up for the primary analysis. Here you see the selected eligibility criteria for magnitude. Again, these inclusion-exclusion criteria are designed to have a patient population which is reflective of contemporaneous patients' populations with ATTR amyloidosis. The phase 3 polyneuropathy study is ongoing as well. It's called Magnitude 2, double-blind placebo-controlled trial, planned to enroll 50 patients randomized 1-to-1 to Nexiguran Ciclumeran or placebo. So in conclusion, a single dose of Nexid demonstrated favorable safety and tolerability profile and resulted in a deep, rapid, and durable reduction in serum TTR with very low variability among patients with ATTR cardiomyopathy and polyneuropathy, so across the spectrum of ATTR amyloidosis. Reduction in TTR were associated with stability or improvement in several markers in ATTR cardiomyopathy with advanced disease, who are expected to have a rapid disease progression and high mortality rates. In patients with ATTR-PN, Nexid had a positive impact in multiple disease-relevant measures, with stability or improvement in most parameters. So the effect of Nexid observed in this ongoing phase 1 single-arm open-label study will need to be confirmed in randomized controlled trials, which are currently ongoing. So these results represent the first clinical evidence of in vivo CRISPR-Cas9 gene editing, showing that targeted inactivation of the TTR gene may impact disease progression and ATTR cardiomyopathy and polyneuropathy. So these results also support the hypothesis that the rapid, deep, and durable reduction in TTR might translate in clinical benefit for patients. And the effect of Nexid on clinical outcomes in patients with ATTR cardiomyopathy is currently evaluated with magnitude, and in patients with polyneuropathy currently evaluated with magnitude 2. Thank you very much for the attention.
Thank you so much, Dr. Fontana. Again, to remind everyone, these slides will be available in the coming weeks on heart.org. Before opening the floor for audience Q&A, I'd like to welcome Kelly Lavender from the Patient Education and Support Team here at the American Heart Association to launch our ATTR-CM educational. And welcome, Kelly.
Thanks so much, Devin. We are excited to announce that the ATTR-CM Educational Toolkit has officially launched and is now available at heart.org/ATTR-CM. This toolkit was designed using insights and feedback from quantitative and qualitative research from the general public, people with ATTR-CM, primary care physicians, and cardiologists. And our goal is that these resources will support both healthcare professionals and patients navigate the complexities of genetic conditions that affect the heart, emerging therapies like gene editing, and clinical trial participation. Next slide, please. So, in the feedback from our general population market research, we found that 92% of respondents said their healthcare professional was their most trusted source for medical information. So, to that end, we created this toolkit as a digital interactive resource that equips clinicians with helpful and simple answers to questions that patients and their loved ones may ask, as well as suggested topics you may want to broach during your discussions. And we use an easy to understand recipe metaphor throughout all the resources to help provide clarity and demystify these complex topics. There's also a list of trusted resources that you can share with your patients. And our goal is that this information allows you to conduct shared decision making conversations and reinforce your standing as their trusted resource. Next slide, please. So, for your patients, we have three different tools. The first is a patient and caregiver guide, which is a digital 23-page interactive workbook that addresses genetic conditions that affect the heart, gene editing, and clinical trials. Our goal was to create culturally relevant, literacy appropriate materials that help encourage those collaborative conversations about participating in gene editing clinical trials so that patients feel supported before, during, and after the decision making process. So these are at a 5th to 6th grade reading level. They include information that's actionable. We've left them places to take notes. And taking insights from our market research, we also included sections that address the concerns and barriers that people have when deciding whether to participate in a clinical trial and or gene editing, and address those throughout. Next slide. And realizing that people learn differently, we have different modalities here. So we also have an infographic so that patients can better visualize how a clinical trial works. This outlines the stages of a trial, what a person can expect during each phase. And this is also included in the overall patient and caregiver guide. So we hope that knowing what logistical elements to expect can help reduce that fear of the unknown. Next slide. We also have a video. Realizing that gene editing can be a complex process to understand, this is a short 2-minute video that visually explains what gene editing is and how it works. Again, pulling through that recipe analogy. And our goal is that after viewing this, patients and caregivers understand what gene editing is and realize that it's something that's being responsibly explored, not something scary or extreme. Next slide. And we know that patients, caregivers, and physicians each face distinct challenges. So, we're hoping that this information about clinical trials and gene editing really helps cut through that fear and confusion and lack of tools, and equips everyone to have those early effective conversations that are grounded in health literacy, and tailored to each audience and aligned with key moments along that patient journey. And in addition to the toolkit, you'll see that we also want to highlight several existing resources already available on heart.org to support both clinicians and patients. So you can scan those QR codes directly from this slide or visit heart.org to search these health topics at any time. And with that, I'll turn it back over to Devin.
Thank you, Kelly. And with our remaining time together today, I'd like to welcome back Dr. Kittleson and Dr. Fontana for our Q&A portion. If anyone has any questions, please feel free to either enter your question in the chat or come off mute to ask your question directly. But we do have some questions that have already come through that I will just kick things off with. Dr. Fontana and Dr. Kittleson, if you can come off mute. So the first question in the chat here is just what parameters establish end-stage disease? And I will defer to you both on who to take that question.
I'm happy to take it, but I'm actually delighted to hear Dr. Fontana's perspective as well. I would say there is no established criteria with which to say end-stage disease. I mean, there's the National Amyloid Center staging system, which Dr. Fontana herself has pioneered. But when I'm thinking about the patient sitting in front of me, what I'm thinking about is, if I start this therapy that does not reverse disease, that simply slows progression, does the patient currently have a level of quality of life that is acceptable and reasonable to work on preserving? And number two, do they meet the criteria of the clinical trials for which benefit of these therapies, tafamidis, acoramidis, vutrisiran, have been demonstrated to work? So for me, in global gestalt, it's you have NYHA class 4 symptoms with limiting hypotension and kidney dysfunction, essentially a cardiogenic shock type picture, meaning I think you're sick enough to need inotropic support because of your advanced restrictive cardiomyopathy from amyloidosis. To me, you've passed the boundaries for which there is any benefit of these disease-modifying therapies. I think short of that, it is very difficult conversation. It's a judgment call, and holding back on therapies, it's a shared decision-making discussion, but I try to outline those uncertainties. But that is a clear population for whom I cannot, it seems to me the therapy is both evidence-wise and clinical-wise futile. Dr. Fontana, I'm dying to know what you think.
I couldn't agree more with what you said. It's really about how is the global evaluation of the patients and the quality of life. And there's no magic cutoff on the anti-proNP, on the troponin, or the GFR that we can pick. And it's really about the overall assessment. And we are doing much more on frailty, for example. These are geriatric populations where it's not just ATTR, but it's the level of comorbidities and the global assessment of the patient. So we need to shift and be a bit less cardiologist and thinking just about survival, and be a bit more geriatrician as well, because is heart failure in the elderly, we cannot ignore the wider picture. So couldn't agree more.
Thank you both. And a couple more here as time allows. First, question for you both as well. What do you see as the most important pitfalls to avoid in ATTR-CM diagnosis?
Dr. Fontana, please.
Okay, no, I mean, I'm sure you're going to go on the same. It's really about excluding a plasma cell dyscrasia is the first most important step, and this is what Dr. Kittelson mentioned in the lecture. Because if you don't have a plasma cell dyscrasia and you've got cardiac uptake grade 2 or 3 on the DVD scan, then you can use no biopsy. But if there is a plasma cell dyscrasia, biopsy with Congo red end typing is absolutely essential for the right diagnosis. And what we find, at least in the UK, but I mean, I think it's the same everywhere, is that as cardiologists, sometimes we like to skip corners. So we would do the free light chains, but then not the BJP in the urine, or not immunofixation by electrophoresis. Instead, the 3 tests that need to be done are free light chains and urine and blood immunofixation. Electrophoresis is not sensitive enough, so shouldn't be used. But here, eager to hear what you think, Dr. Kittelson.
No, absolutely. And I think the other pitfall I would encourage you, sometimes your technetium scan is equivocal. It is not positive, but you just know this is a slam dunk cardiac amyloidosis. Remember, your pretest probability guides your post-test probability. So look at the patient, not just the test result, and empower yourself to dive further, perhaps with an endomyocardial biopsy, if their picture is so classically amyloidosis, negative monoclonal protein screen, equivocal radionuclide scintigraphy scan. Perhaps they have a rare variant that won't show up. Perhaps they have a rare variant that's not TTR. But in that situation, rely on your clinical gestalt, not just the test.
Absolutely. Whenever something doesn't fit, we have to go for a cardio biopsy. Couldn't agree more.
Thank you both. And just in the spirit of time, any additional questions that we did not have the time to get to, we will reach out to you all via email. Thank you to everyone for joining us. As we wrap up, we invite you to stay connected to the rest of our ATTR-CM educational webinar series. Webinar 3 will take place in December of this year, focusing on ATTR-CM in practice, new therapies and precision approaches. And our 4th and final webinar in the series will follow in February of 2026. 2026, highlighting multidisciplinary care models and future directions. Stay tuned for registration details. We hope you'll join us for both upcoming webinars. Feel free to scan the QR code or visit www.heart.org/ATTR-CM to stay up to date. Thank you to everyone for joining us again today. Recordings of today's session will be available in the coming weeks on heart.org. Thank you, Dr. Kittleson, and thank you, Dr. Fontana.
Thank you.